We'll go through the rest of the spine today. T-spine, S-spine. T-spine won't take all that long. There's not a whole lot we do with the T-spine. We'll talk about L-spine, sacrum, and coccyx, and talk about some of the things to look for on the test. We'll start with anatomy. So thoracic vertebra, we have 12, just like the ribs, we have 12. And we talked about last week how we identify individual vertebra. Every type of vertebra has something special, right? So the cervical vertebra had bifid spinous process, but it also had the hole in the intervertebral, or I'm sorry, the hole in the transverse process. And that was for the vertebral artery, right? So in the thoracic vertebra, and we even looked at that last week, we had some facets on that for the ribs themselves. So we had facets where we had articulation, not just with the vertebra, between the vertebra, but also where we have articulation with the ribs as well. So on the test, if you see a vertebra that has these little dots on it, on the transverse process or on the body, then that's going to be a thoracic vertebra, right? If it's got a hole in the transverse process, that's going to be a cervical vertebra. All right. So what if it has neither one of those? It's going to be a lumbar vertebra, right? So absence of those is what's different about the lumbar vertebra. So in the lumbar vertebra, we typically have 5. In rare cases, you'll see a patient with 6, and also in rare cases, you'll see a patient with 4. And sometimes it's more common, but sometimes you'll see what we refer to as transitional vertebra between L5 and S1. So L5 takes on the shape more like a sacral segment than what it looks like the rest of the vertebra. And what I mean by that is that the sacrum, let me just get to an image of the vertebra. So instead of blocky like that, it's more wedge shaped. And it's not wedge shaped because the patient has a compression fracture. It's just their normal anatomy. Also, what you'll see sometimes in L5S1 is I won't say it's a natural subluxation, but it is patient's anatomy. There is a subluxation there. It's called spondylolisthesis. And I'm not going to spell that out because I'll trip all over it, but it's called spondylolisthesis, and it looks pretty bad whenever you first see it. It's really not all that significant, largely because the spinal cord ends at L1. Now, you still have nerves that go down through the spinal canal and exit at different places, but the spinal cord itself is already done at the cauda equina around L1. All right, so it looks pretty awful, but it's not as bad as what it appears to be. So the sacrum then is kind of like a number of vertebrae that are fused together to create one big bone, and its articulation with the iliac bones of the pelvis are at a place we call the sacroiliac joints. So the iliac bones here, and then we got the sacrum, and the iliac kind of wraps around the backside of the sacrum, so that we've got a fibrous joint there, and it doesn't move much. It might move slightly, but not very much. But it is a site where we see some arthritis. This poor guy, this poor guy has you can see they've moved more than what they should. I need to screw the screws down a little bit tighter. But it does allow for a little bit of movement, not this much, I mean, these truly look like wings. They're going to fly away, right? So the sacrum, if you notice, again, we get into that kyphotic curvature in the sacrum and the coccyx, and then the coccyx, the bones of the coccyx vary from 3 to 5. So that's what we refer to as the tailbone. But again, our point that we sit on would be right down here. We don't sit on that little bitty bone. His anatomy is messed up. I'm gonna have to. The screws are different. Okay, so I'll have to work on him later on. So we do have views where we can see the SI joints, and you may be able to visualize those as oblique this guy up, and that gives you a little bit of prelude as to what we're going to be looking for on that. So, not going to ask you for the prominent features. You will, need to know what the SI joints are. And the coccyx, again, not going to look for individual features. You just need to know where it is, what it is, and how many possible bones could make it up. So, sacrum, coccyx, from a lateral perspective, sacrum and coccyx. In a lot of cases, whenever we image sacrum and coccyx, we'll image them together, right? So we'll do it's almost like a series, sacrum and coccyx series. Okay. So general procedures, I'm gonna get this guy out of the way for now. But general procedures, your trauma situations, you're gonna do 2 views, and you may have to deal with some artifacts, right? Because the patient can be on a backboard. But if it's a walkie-talkie patient that comes to you not on a backboard, then you need to get pretty much everything out of the way. Thick waistbands are going to show up. Snaps, buttons, all that kind of stuff are going to show up as well. So you need to kind of get that stuff out of the way. So dress your patient for the procedure, if at all possible. If they're on a backboard, of course, that doesn't really apply. You may have to deal with seat belts and all kinds of other stuff as well. Okay. So patient preparation, just get all the artifacts out of the way. In the gown, ambulatory patients, you can do upright. I kind of don't recommend upright. I've never had a whole lot of success with taking our exams with patient upright because the patient has a tendency to move. Especially whenever we're doing a lateral. With a lateral T-spine, we're going to be doing a breathing technique. So the possibility the patient will be in motion throughout the exposure is pretty good. So, use your discretion. If you have good luck with upright, have at it. Some of our procedures we're gonna do upright, but for standard normal procedures, I tend to do mine with patient on table. And trauma patients, we're gonna do a lot of cross table. Also with trauma patients, we're gonna do some things that are a little bit different with our trauma patients. So the trend right now is for patients who are truly in a trauma to go straight to CT, right? So we're not doing a whole lot of trauma procedures in the trauma room diagnostic x-ray. We can, but just, CT just shows us much more stuff, right? So we tend to send the patients directly to CT. But if you happen to be working in a hospital where you actually do plain film radiography on trauma patients, there's a couple of things we're going to be doing a little bit different. Like, for example, you probably won't do an AP T-spine even if they suspect a T-spine fracture, possibly in follow-up, but your initial T-spine image is actually just going to be a chest x-ray. So your first image in any trauma situation is always going to be a chest x-ray. Because it doesn't matter what else is going on with the patient. If their lungs are filling up with fluid, or they got a bilateral pneumothorax or whatever, and the patient's going to suffocate, it doesn't really matter what's going on with the rest of the patient. The patient's not going to make it off the ER table, right? So chest x-ray is always our first one, and the T-spine is going to be, the chest x-ray is going to be our T-spine too. Likewise, in the L-spine, even though it's not as urgent, if we shoot a KUB on L-spine, or shoot a KUB on a trauma patient, the L-spine becomes KUB becomes L-spine too. That makes sense. Okay. All right, so your image size or collimation field restriction is going to be roughly 7 by 17 on both of these. The L-spine could be a little bit less than that. It could be something more like 7 by 14. You can even collimate in a little bit less than that. The width may be a little bit smaller than that. Markers, that. Collimation is going to be your primary radiation protection. You could do some sort of shielding, maybe shadow shielding or something like that, if it didn't interfere with the anatomy. So essential projection is a T-spine or AP and lateral, but we're going to talk about obliques as well. Now, just like in the C-spine, the T-spine is never just going to be AP and lateral. And the reason for that is because the T-spine, much like the C-spine, what's going to be over the upper portion of the T-spine? Okay, ribs always. The sternum's going to be anterior, but how about the shoulders, shoulder blades, right? You shoot a lateral chest x-ray, and can you see C17-1? Answer is no, you can't, because shoulders are in the way, right? Part of that is because shoulders, you got the arm straight up over the patient's head. For a lateral of the T-spine, we're going to put the arm straight out front of the patient. But how do we see C17-1 on the C-spine? What do we do if you can't get the shoulders down? Okay, angle, but there's something else. Swimmers. Yeah, we're going to do swimmers. So we're not going to go back through a swimmers, and we're just going to float that out there. You always have to do a swimmers with a T-spine. Okay, just like the open mouth odontoid completes the AP, right? The swimmers completes the lateral on the T-spine. So where you might not have to shoot a lateral you might not have to shoot a swimmers to include with the lateral C-spine, you always have to do it with a lateral T-spine. So essential projection is really three. You've got your AP, and you've got your lateral, and then the swimmers completes the lateral. Okay, so you get a request in the hospital for AP and lateral T-spine, you got to throw in the swimmers. But we're going to talk about obliques as well. So the positioning, if you've read through the positioning is really similar to a chest x-ray. So if you look on page 462, what were our steps for a chest x-ray? Where did we put the image receptor? 1.5 above shoulders, right? Where do we put central ray?
Jugular notch.
A little below the jugular notch to T7, right? So those two things are going to be identical for both the AP and the lateral T-spine. Okay, no difference between 1.5 above the shoulders, top of the image receptor, central ray to T7, just like on a chest x-ray. The obvious difference is if you're just shooting for the T-spine, you're going to collimate, right? Instead of using the outer cells, you're going to use that inner cell. You're going to collimate in just the T-spine. We talked about scoliosis last week, right? Okay, so you don't know if a patient has some mild scoliosis, especially if they're a larger patient. You may have if they're a little bitty patient. I told you about my mom, right? She's 100 pounds soaking wet. You can look at her back and you can kind of see some curvature there. But if a patient has any kind of size on them at all, you might not be able to see that curvature. So I would encourage you to resist collimating into what you think is just going to be the width of the T-spine. The T-spine is not all that wide, right? So your collimation, theoretically, you collimate into a shadow about 2 inches wide on the front. Problem is, if you have any kind of curvature at all, or if you're not, on the table perfectly straight, you're going to miss some anatomy. Okay, so collimate tightly, but don't overdo it, because you may have a patient with some mild scoliosis and you may project them off. Another thing is whenever you lay flat on the floor, legs are extended, you lay flat on the floor. How's your back? It's got a curve and it comes up off of the floor, right? So what you need to do on both the T-spine and the L-spine is to flatten out that lumbar curvature. To flatten out that lumbar curvature is to bend the patient's knees. All right, so you can put a pillow under the knees, or you can put a one of those angle sponges under it doesn't really matter. Just put something under the knees, especially if the patient has socks on. If they don't have socks on, they tend to not, the feet tend to not slide across tabletop quite as easily. If they're barefoot, if they've got socks, or if they have those grippy socks. But if they have socks on, by the time you get back around to make your exposure, if it's an older patient, probably their legs are going to straighten back out. So bend the knees up on both of those to take out that lumbar curvature. Shoulders in the same horizontal plane. If the patient is upright, make sure that the weight is evenly distributed on the feet. All right, so what this is referring to down here at the bottom, if possible, orient the patient so that the lower thorax is at the cathode end of the x-ray tube. as Amy talked about the anode heel effect. Okay, that's what that's referring to. The greater intensity at the anode end of the X-ray tube. Since there's a greater intensity at the anode end of the X-ray tube, we'll put the thicker anatomy on that end. Full disclosure, you just don't see the effects of the anode heel effect the way you used to. The computer processing and the computer algorithm kind of evens out the tissue density difference. So if you forget that step, and best case scenario, you want to use that step. But if you forget that step, chances are it's not going to be a repeat just because of that. Okay. So the effects of that anode heel effect, it's still testable. So we still have to teach it, but the effects, in all honesty, are not as great as what they used to be. So just like what we were talking about before, put the top of the image receptor 1.5 to 2 inches above shoulders, put the central ray at T7, perpendicular to the image receptor, bend the knees up. So that is going to be halfway in between the jugular notch and the xiphoid process. Collimated field, 7 by 17, 5 by 17. I wouldn't come in any smaller than 5. So we want to be able to visualize all 12 thoracic vertebrae, and one way that you can even out some of the tissue density difference is to image the patient on exhalation. Okay, so if you have a patient taking a big deep breath and blow it all the way out, that takes all that lung tissue and it kind of collapses it into the upper portion of the thoracic cavity. So it makes it more similar to the lower portion of the thoracic cavity, and it makes everything look a little bit better. So all 12 thoracic vertebrae without any kind of rotation, and alignment to the middle of the radiograph. Make sure that you don't have a patient going across the table. So it should look like that. So we're just looking for the vertebra that have the ribs attached to it. So that'd be, and it's sometimes easier to look at the bottom. No rib. So 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So we don't see any ribs above that. We don't see any ribs below that. We can see all the vertebra. That looks pretty good. Okay. So lateral, again, you can do it upright or with the patient laying down. I prefer laying down, especially on the lateral, because of that breathing technique that we're going to use. It's going to be, 3 seconds. And if the patient's upright and they wobble just a little bit in that 3 seconds, you're going to have some motion artifact. So I prefer to have my patient laying down. Laying down does come with some issues as well, though. But what we're going to do is roll the patient up onto their side, have them bend their knees and put their knees right on top of each other. Knees and feet stacked. If the knees aren't stacked, you bend them. And if the knees aren't stacked, you're going to get some rotation on the lower end, right? And then our arms, instead of having them straight up over our head like a lateral chest x-ray, they're going to go straight out in front of the patient. Okay, so you can say, put your hands out in front of you like you're praying. That usually gets the point across. And knees and ankles stacked on top of each other. Step back and take a look at the patient and make sure that they're not rotated in some way. Also, though, when you step back, look at the patient's spine. So the spine, you want to have it parallel to the image receptor, which would put it perpendicular to the central ray, right? I'm not talking about the disc spaces. I'm talking about the spine itself. So if you take a step back and you look at the patient's spine, the divot in their spine, see if it's parallel. Sometimes it's going to be at a little bit of a dip. And the reason for that is because, if a patient has small waist and broad shoulders, then, you're going to have an angulation on your spine. It's more prominent most of the time in men because men tend to have broader shoulders than women. And so you've got to do one of two things. First off, if you've got a patient that just doesn't have, any, I don't mean this to sound tacky, but, doesn't have a whole lot of curves to them, be it male or female, then you might not have to take any kind of precautions at all or any additional steps. But, take a step back, and if it looks like you got an angulation on that spine, what you may have to do is build the spine up to make it parallel. Okay. You're probably not going to be seeing this happen a whole lot in clinicals, People just don't want to take the time to put stuff under the patient. Plus, our computer algorithms do such a good job of, showing everything that it's going to cast an artifact in a lot of cases. So what you might see then, rather, is angulation of the central ray. So if you don't build the patient's spine up to be parallel with the table and therefore the IR, then what you need to do is angle the central ray until it's perpendicular to the spine. Okay, so the book says that's going to be 15 degrees in men, 10 degrees in women, but it's really going to be according to the patient's anatomy, right? So if you have a patient who has, they've got some features there, but they're not all that significant. Even if it's a man, you may only need 5 to 10 degrees cephalic angulation. So take a step back and look at the patient's spine, and then angle your central ray accordingly. Does that make sense? But remember, that's for practical use. But remember, the test question is going to be 10 degrees cephalic for women, 15 degrees for men. We're going to do the exact same thing on the L-spine, but we're going to do it slightly different angulations in the opposite direction. So completely not exactly the same thing. We're going to do something, similar to, I guess. Okay, so we'll talk about all that. Also, because on the lateral T-spine and the lateral L-spine would create a lot of scatter radiation, what you'll probably see people do is take a lead apron and put it behind them to absorb scatter radiation that's striking the image receptor. That's not going to do anything for patient dose, and it's not truly collimation. It's just a blocking of that information from getting to the image receptor and going into the computer algorithm to create your image. Okay, so it's just cleanup. It's almost like a secondary level of beam restriction, but it's post-patient beam restriction. Okay. So your central ray is going to be to the mid-axillary region, which is coming right down from the armpit, and you're going to have a tendency to want to think, well, the vertebra is way back here in the thoracic spine, and I would bet that your most common mistake is going to be to position too far posteriorly. Okay, so resist that. Part of the reason that we're a little bit more anterior is because that curvature of the spine, the spine is not just straight up and down. So we're going to have to go just a little bit more anterior than what you might feel comfortable going. Okay. So if you're setting a technique, what you would want to do is you would want to use a principle we're going to talk about in physics is called reciprocity. Anybody know what that means? Just a word, reciprocity. What is a reciprocal saw? Anybody ever worked with a reciprocal saw? It's just saw that goes back and forth real fast. A lot of people call it a sawzall or a jigsaw. It's a blade that just goes in and out and in and out and in and out. And it's called a reciprocal saw, reciprocating saw. And what that means is give and take. Okay, so it's give and take is what it is. So what is mass? What is it? I don't mean mass as in, I mean quantity. It's quantity of electrons, so it's quantity of photons, right? So does it matter how we get to a specific mass? Is 100 MA at 1 second 100 mass? Is 200 MA at half a second 100 mass? Yes. Okay. So that's reciprocity. That you're giving up one thing and you're taking another thing to arrive at exactly the same thing. Is what reciprocity is. The law of reciprocity means that if your machine's shooting right, it doesn't matter what MA in time you're using, the overall mass is going to be what controls your exposure in the X-ray beam. Okay? So if you're wanting to do a lateral T-spine, and let's say you need 100 mass, then what you're going to have to do is lower your MA to increase your time, right? To arrive at 100 mass. So, you may have a patient who's so small that you can't get a 3-second exposure. The book says 3-second exposure is ideal. You might not be able to get a 3-second exposure, but you probably get a 1-second exposure on anybody. If you back down to 100 MA, 1-second exposure, you could get that. Is that going to be enough time to get an adequate breathing technique? Depends on how you go about it, right? So if you make your exposure and the patient, is at the end of exhalation, and you're making your exposure, then you're only going to get about half of that movement, right? So what you might need to do is, if that's the case, you're using a breathing technique, maybe you're doing a portable. In a trauma situation, a lateral T-spine, portable 100 mass is going to be a 1-second exposure. So what you may have to do is have the patient take in a deep breath, tell them slowly blow it out, and while they're blowing it out, make your exposure. Okay. So use reciprocity, get 3-second exposure if you can. If you can't, then do what you can with whatever exposure you can get. But again, T1 through T3 are not well seen, so we're going to have to do a swimmers every time, right? So that's breathing technique. Without the breathing, these are lung markings up here, kind of in the howler region. They're pretty dense, and even them, you don't see them very well. The ribs are pretty well blurred out, right? So good breathing technique. So we have, T-spine fractures tend to be compression type fractures. This is just a nasty right there. That's more than a compression. That's more of a shear type fracture, and I've not seen that before. I've seen compression fractures in the T-spine, and sometimes associated other fractures in C-spine or L-spine or whatever. It seemed, I used to work in surgery, and for 2 or 3 years in a row, we had patients that would come in with T-spine fractures. They were unloading round bales of hay. Round bales of hay are 700 pounds or so. It's a lot of hay. And they were unloading these things, and generally you just, you have a tractor to unload them, right? And I think it was 2 years in a row we had one of those fall on somebody, and it seemed like at least one of those cases the guy was trying to stop it from falling. How well do you think you would catch 700 pounds worth of anything? But it's just grass. Yeah, it's just grass, but what weighs more, a ton of lead or a ton of feathers? A ton is a ton, right? So 700 pounds worth of grass will squish you, all right? So, I don't know. I guess moral of the story is don't try to catch grass. But yeah, that was probably the worst T-spine fracture that I ever saw, and it did wind up with some degree of paralysis. So this is something that I kind of threw together this morning. Some things that are difficult to grasp on the test is what you see and where you see it. Okay. So let's look back. That's not ideal, but you see this one right here, this lateral T-spine. See that big dark area right there? What do you suppose that is? Intervertebral foramina, right? So the test is going to ask you for what you see and where you see it on each one of the the anatomies that we're going to cover: T-spine, L-spine, and C-spine. So we saw the zygapophyseal joint on lateral on a C-spine, right? So it might ask you where you're going to see the intervertebral foramina, and that's going to be that hole right there, and that was a 45-degree oblique with cephalic central ray angulation with patient AP, right? So AP was on the upside. That means that PA would be on the downside with caudal angulation, right? So C-spine, we're going to see the intervertebral foramina on the oblique, right? We're going to see PA on the downside, AP on the upside. And then we're going to see zygapophyseal joint on lateral. On a T-spine, we're going to be looking at the intervertebral foramina on the lateral, okay, which means we're going to see the zygapophyseal joint on the not lateral, the oblique, right? So the oblique, since it's not in here, I want to direct you to page 468. The obliques on a T-spine are the steepest obliques that I think we've talked about yet. I think Gracie came pretty close, but that was about it. So if you read through the description and you're looking for numbers, the middle of the middle paragraph or column says that we're going to use 20 degree oblique, but that 20 degrees is from lateral. Okay, so it's really a 70-degree oblique. So get the patient into a lateral position, and again, full disclosure, I've never shot intentionally oblique T-spines in my entire career. You just don't see them a whole lot. You don't see a whole lot of T-spines, but certainly you don't see a whole lot of oblique T-spines. It's generally just going to be AP and lateral. Anything beyond that, patient's going to go to CT. So it doesn't, again, matter if you're doing AP or PA, but it's going to be a 70-degree oblique. So get the patient into the lateral position, and then either oblique towards the image receptor, and make sure you move the patient as a whole, right? Don't leave the knees stacked and just rotate like that. You're going to have to unstack the knees a little bit, get them rotated towards the image receptor or towards the central way away from the image receptor. Okay, so 70-degree oblique, central ray is going to be in the same spot. And what we're going to see then is the zygapophyseal joint. On AP, we're going to see the zygapophyseal joint on the upside. On PA, we're going to see it on the downside. And then the lateral, we're going to see the intervertebral foramen. So notice that, notice that the anatomy has changed, right? The anatomy has changed. We went from zygapophyseal joint on the lateral to intervertebral foramina on the lateral, but what side that we see it on remains the same. All right, so on the AP, we're going to see it on the upside. On PA, we're going to see it on the downside. When we get to L-spine, this, what we see is going to remain the same, but where we see it is going to flip. Okay, so we'll take a look at that here in a minute. So any questions on T-spine? Okay, then L-spine, our essential projections, again, are going to be AP and lateral. We may have a L5S1 spot that we may have to do again because of the computer algorithm. That's becoming more and more rare that we actually have to do that. Usually occurs whenever we have a patient who's got a little bitty waist and then broad hips. And we're going to do our obliques, and then we'll do SI joints as well. So our AP of the L-spine, depending on if we're doing what we refer to as a lumbosacral spine or just a straight L-spine, our collimated field and our positioning will change just a little bit. All right, so the basic housekeeping, the coronal plane is going to be parallel to the IR, which puts it perpendicular to the central ray. Mid-sagittal plane should be perpendicular to the central ray, parallel to the IR, or perpendicular to the IR, parallel to the central ray. So have the patient put their hands down to their side, across their chest, somewhere out of the way. This and KUB kind of have the same. You have the same problem with it. You get the patient all positioned and they're cold because it's cold in the hospital. You put a blanket or a sheet over them to, maintain their dignity and maybe keep them a little bit warmer. And you put the sheet over their arms and you go back to making exposure, and then you come back and you've got not only a KUB, I've seen some nods like this has happened. You've seen it? Yeah. So you come back and you not only have a KUB or an L-spine, but you've also got a pair of hands as well. So get them up out of the way, somewhere that you can see them. Put them on top of the sheets, on top of the blanket, somewhere that you can see them to make sure that they don't do that. Again, bend the patient's knees to flatten out the L-spine, reduce that lordotic curvature, and bring the L-spine more in line with the more parallel to the image receptor. Opens up the joint spaces a little bit better, the disc spaces. All right, so if you're looking for the lumbosacral, you look for the entire sacrum, you're looking essentially all the way down to the coccyx, then you would position kind of like what you would do for a KUB. You'd position right at the crest. All right. If you're just looking for the L-spine, this is more hospital protocol, doctor preference than anything else. If you're looking for just the lumbar spine, then your collimated field would be more like a 7x14, and you would position about 1.5 inches above the top of the crest. Some doctors are going to want to, even on a non-trauma patient, they're still going to want a KUB. The reason for that is a lot of things can cause back pain. Kidney stones can cause back pain can cause back pain, gallstones can cause back pain. It's hard to identify exactly what's going on with the patient. So some of your doctors are going to want, instead of a collimated AP, they're going to want you to shoot a KUB for the AP of the L-spine. Okay, so know your doctors, know your protocols, and regardless of what we say up here, this is for testing, but in clinicals, do what the doctor wants. Okay. So you want to see the anatomy of interest, regardless of whether it's just the L-spine. You got to see down to the top of S1. But if it's the lumbosacral, you want to include all the sacrum and coccyx. You don't want any kind of rotation. Open disc spaces in as much as they can be. And I say that because of the lordotic curvature. The spine, the L-spine, is exactly opposite from the divergence of the central ray, right? So the disc spaces on the L-spine are going kind of like this, all right? So they're facing you like this disc space, disc space, disc space, disc space. Central ray is diverging like this, okay? So they're not going to be parallel to each other, right? They're going to be bumping into each other. And what you're going to see then is, instead of the vertebra having that nice squared looking appearance like that, you're going to have some of that going on. Okay. So how could we get rid of some of that? How could we make it not like that? Just so you know, you're never going to do this, but how could you theoretically? All right. Now your disc spaces are going like that, and your central ray is going like that. Now they're parallel to each other, and you can see open disc spaces a whole lot better. So unlike the wrist, why do we not do this? Why do we not shoot our patient's PA? This guy's falling apart. He's brain nuts. What's that? OID. Okay, OID is one. Very good. Somebody else said something. Ever have back pain? Anybody? Got too young for back pain. You'll get there. Okay. How well does it feel laying on your stomach if your back is really hurting? Not usually very good, right? So just for patient convenience, and because it's going to hurt if you put the patient on their stomach, we're going to shoot AP. And the best that we can do to get rid of some of that, seeing the end caps of the vertebra, the best we can do is bend the knees up and try to straighten out the lordotic curvature of the L-spine. Okay. But OID as well. OID, we're going to increase magnification, decrease sharpness for the detail. So we're going to see open disc spaces. sort of ish, right? And then, all the tissue and all that. So that's what it should look like. Again, just like on the T-spine and the C-spine, we should see spinous process right in the middle of the column, and that's what you're looking at right there. Okay. So this is obviously a lumbar spine. You just don't see the coccyx. If it was a lumbosacral spine, you'd see all the way down to the symphysis pubis. Okay, so I'm going to skip over lateral bending. We'll get to it here in a minute, because we got to do flexion and extension and bending on lateral as well. So with lateral L-spine, we're going to use the same steps that we took for a lateral T-spine. Get the patient's knees stacked on top of each other, their feet stacked on top of each other, get their arms out in front of the patient. The problem with lateral L-spine, if it's T-spine, the patient kind of gets it, but if it's L-spine, they kind of have a tendency to just roll up a little bit, right, and just want to leave their lower body in the same spot, and it's just not going to work for them. So get everything stacked. Take a look at the patient, make sure that there's no kind of rotation or anything. Get everything stacked on top of itself. Hips superimposed, knees, feet, arms out in front of the patient as well, just like on the T-spine. If the patient, take a step back and look at that little indentation where the spine is, and if it's parallel, then you're golden, right? If it's parallel to the tabletop and it's parallel to the image receptor, then your central ray is going to be perpendicular. So where we have issues in the L-spine, again, is with patients who have narrow waist and wide hips. So this is usually thinner women. All right. So what then we have to do is either build up the L-spine or angle caudally. Okay. So with the angulation on the L-spine is going to be, again, according to the textbook, 7 degrees caudal in women and 5 degrees caudal in men. Men's hips tend to be less broad, right? We tend to have a little, the difference between your hips and your waist is less significant. So more angulation in women caudally for L-spine as opposed to T-spine is more cephalic in men. All right. So what we're trying to avoid here is, again, the thing that I was showing a second ago. Now, if you go to surgery, it becomes vital that they be able to see that vertebra and it looked like a block. Okay. So some of your surgeries that I was talking about the other day, last week, we talked about a laminectomy, right? Cutting the lamina out so that the spinal cord and the sac around it has some place to go, right? So what they're going to do in some cases, though, is they'll put plates and screws into the patient's spine as well. So some of those screws follow the pedicle, they're called pedicle screws, into the body. So the pedicles should be strictly superimposed, and what they're going to do is use a C-arm, portable fluoro, in order to visualize this. All right. So if they have a good squared body, they can see exactly where the pedicles are, and they can see exactly where the screws are going. If, though, your C-arm is at an angle, giving you that appearance, like what I was showing you with the paperclip thing a second ago, what you're going to see is not a square-looking vertebra. It's going to look kind of like an artist rendering of a tube. Okay, so you're going to see the top and the bottom of the vertebra, at least in part. So when they put the screws in, the pedicles should, normal anatomy should parallel each other perfectly, right? So if they get one screw in a good spot and they're watching it under fluoroscopy, then the second screw should be right on top of the first one, right? But if you're looking at that, and that is what you would call non-coplanar, this is not on the test, But if you hear this mentioned in surgery, that's what they're talking about. They're going to say you're not coplanar. And what they mean is you need to move your C-arm until your vertebra looks again like that. Okay. So you hear that mentioned if you're doing a spinal fusion, they're putting pedicle screws into the patient. So that way it takes the guesswork out. They get one screw in and they can just follow the trajectory, and the next one should be perfectly superimposed on the other one. Okay. So coplanar, square vertebra, non-coplanar, make it square is kind of what they're driving at. So our neurosurgeons do a lot of spinal work around here, and they get pretty particular about that. Pretty obvious reasons. All right. So lateral the L-spine rather, you're going to struggle with this too, because the lumbar curvature is also going to be a hard thing to try to figure out exactly where to set. Lumbar curvature gives us a, how do I collimate to this? Where do I position? How do I keep from mispositioning my central ray and clipping anatomy? Well, if you look at this image, you see this dark or this dense. It's not dark. It's a light density that's coming right across there. What do you suppose that is? The iliac crest. It's the highest point of the iliac crest. So if I put the highest point of the iliac crest and I go here, right, and that's touching the highest point of the iliac crest to the very front of the vertebra, right? What's sticking off the back of the vertebra that you can't really see on this because it's burnt out? Spinous process, probably sticking out to about there. Is that pretty much dead square in the middle of the vertebra? If you get your patient positioned properly, you get them rolled up and their hips are on top of each other, you get them in a good lateral position, and you find the highest point of the iliac crest, and you put your long line of collimation straight up and down from that. Just pay attention to how much curvature the patient has and adjust your collimation accordingly. But that is going to be, your zero and end point, for exactly where to put this line of collimation. Now it's just a matter of this line of collimation centering. It's just a matter of getting your collimation right. Okay. You see this right there? You know what that is? Any idea? Can't see it? This a little bit of increased density right there, or increased patient density, decreased radiographic density. Can you kind of see what I was pointing at over there? No idea? I don't know this for sure. We'd have to see more x-rays. But so when a patient has an abdominal aortic aneurysm, you know what aneurysm is? It's weakening in a blood vessel, causing the blood vessel to swell up. And it's kind of like a water hose. You get a weak spot in a water hose and you crimp it off. What happens to that weak spot? It starts to bulge until eventually it goes, right? That's kind of what an aneurysm is. It's a weak spot in an artery, and what happens is the body identifies that weak spot and it adds calcium into it to strengthen it. Okay, so in a lot of cases, if you see something that looks like a collection of bone that doesn't really look like bone just in front of the vertebra, L-spine, it's a good indication that they've got some amount of an abdominal aortic aneurysm. That calcium just gives strength back to the weakened part of the blood vessel and makes it a little bit more stable. Where you have real danger in a AAA is if it doesn't have that. And I don't know if I've related this little story, but I had a patient one time. It wasn't mine. I was a clinical instructor at what is now UT. And I had a student that was getting ready to have scoliosis too. I had a student that was getting ready to do an IVP on the patient, and we shot the scout on the patient, and there was this weird football shaped density that looked like soft tissue with just the tiniest amount of calcium in it, right? But it looked like the size of a football sticking out on either side of the vertebra. There's only one thing that could have been, and that was a massive AAA. We're getting ready to do an IVP on the patient. I don't know if you know what an IVP is, but we inject the patient with 100 cc's of contrast directly into the veins. So that circulates inside the patient's body, right? Increasing the blood volume, probably the blood pressure in the patient. You know, if you ever see anything like that in a patient, it needs to be brought to the radiologist's attention. You know, say, the patient's still on the table. I think you need to take a look at this. You know, if we'd have injected that patient, increase that blood volume, the patient probably would have been dead on the table in about 10 seconds. It was massive. The aneurysm alone probably had a liter of blood in it. It was huge. So we sent the patient over to CT. They did CT on the patient. The patient was in surgery the next day to take care of that aneurysm. All right, so that was rabbit trail. Any questions on lateral, AP and lateral? Why don't we take about 10 minutes and we'll come back and we'll talk about obliques as well. We'll take a look at this again.